It's one of the most common back pain procedures in America. Around 25% of all Medicare epidural injections are for spinal stenosis. And in 2014, a 400-patient trial in the New England Journal of Medicine asked a question nobody had rigorously answered. How much of the benefit actually comes from the steroid? Welcome to the educational channel of Dr. Ryan Kuda, a board-certified interventional pain physician serving the Chicago area. On this channel, we break down the research that shapes how pain medicine is actually practiced. Today, we're presenting the LESS trial. Lumbar spinal stenosis is what happens when the bony canal that holds your spinal nerves narrows over time, usually from age-related changes in the joints, ligaments, and discs. It causes the classic walking tolerance problem, leg pain, heaviness, or numbness that gets worse the longer you're upright, and better when you sit or lean forward. Epidural steroid injections have been a workhorse treatment for decades. The question this paper asked wasn't whether they work. It was how much of the work the steroid itself is doing. The trial was called LESS, Lumbar Epidural Steroid Injection for Spinal Stenosis. In plain English, if we give one group steroid plus numbing medicine and the other group numbing medicine alone, does the steroid actually add anything? Formally, in PICO terms, in adults age 50 and older with imaging-confirmed central lumbar spinal stenosis and moderate to severe leg pain, does an epidural injection of glucocorticoid plus lidocaine, compared with lidocaine alone, improve pain-related disability and leg pain at 6 weeks? This was a double-blind, multi-site, randomized controlled trial. 16 sites across the United States, for 100 patients enrolled between 2011 and 2013, 200 per arm. Inclusion was clean, age 50 or older, MRI or CT confirming central spinal stenosis, and moderate to severe leg pain plus disability. All injections were done under fluoroscopic guidance, so this is real, clinically delivered care, not a research lab artifact. The choice between an interlaminar approach and a transforaminal approach was left to the treating physician. Same way it works in actual practice. The two primary endpoints, both measured at 6 weeks. The Rowland-Morris Disability Questionnaire, a 0 to 24 scale where higher means more disability, and leg pain intensity on a 0 to 10 scale. Critical point about the comparator. This was not steroid versus nothing. It was steroid plus lidocaine versus lidocaine alone. Both groups got an actual injection. Both groups got the procedure. The trial isolated one variable. Did the steroid component add value on top of an injection that already had lidocaine in it? The headline result. At 6 weeks, both groups improved. Their pain went down. Their function went up. And the steroid group's improvement was not meaningfully better than the lidocaine alone groups. The numbers. Patients with at least a 50% improvement in RMDQ at 6 weeks. 23.8% of the steroid plus lidocaine group versus 20.2% of the lidocaine alone group. P-value 0.39. Not statistically significant. Patients with at least a 50% improvement in leg pain at 6 weeks. 38.3% in both groups. Identical. P-value 0.97. A few important subgroup findings. Transforaminal injections showed no benefit from the steroid at 3 or 6 weeks. Interlaminar injections showed a small steroid advantage at 3 weeks, a 2.5-point RMDQ difference, and a 0.9-point pain difference. But that gap closed by 6 weeks, and the authors flagged it as minimal clinical significance. Safety. More adverse events in the steroid group. 0.29 events per patient versus 0.17. P-value 0.02, and measurable cortisol suppression, meaning the steroid was being absorbed systemically. Every paper has limitations. Free matter here. First, and this is the big one, there was no sham control. So the question this trial answers is not, do ESs work better than nothing? It's, does the steroid add to what an epidural injection of lidocaine alone already does? Those are different questions, and treating them as the same is the most common misreading of this paper. Second, the lidocaine arm had more acute pain patients at baseline. Post hoc adjustment for that didn't change the pain conclusion meaningfully. Third, the choice of approach, the specific steroid, and the dose were all left to the physician. So the trial reflects real-world practice variation rather than a single uniform protocol. So what does this mean in practice? A few things. First, the most important, This trial does not say epidural steroid injections don't work. It says the steroid component, on top of an injection of lidocaine, doesn't add a clinically meaningful amount at 6 weeks. Both groups got better. That improvement is real. But the question of how much credit goes to the steroid versus the injection itself versus the natural course of spinal stenosis versus regression to the mean, that's the question the trial doesn't fully answer. Second, the transforaminal-vs-interlaminar finding has practical weight. If the small advantage was confined to interlaminar at 3 weeks only, that's worth knowing when planning a series. Third, the adverse event signal is real. Cortisol suppression matters for older patients on other steroid medications, patients with diabetes, and patients who might be getting multiple injections over a year. Fourth, professional guidelines. The Cho Systematic Review in Annals of Internal Medicine in 2015, which evaluated 63 trials including LESS, concluded that for spinal stenosis, epidural corticosteroids produced no significant short or long-term effect on outcomes. A separate Cochrane review by Oliveira and colleagues in 2020 on lumbosacral radicular pain reached a more nuanced conclusion: moderate quality evidence for a small short-term benefit on leg pain. After this body of evidence, the language in most guidelines became more cautious. Epidural steroids for stenosis are still offered, but framed as one option in a multimodal plan: physical therapy, weight-bearing modification, walking aids, and surgery for severe cases. For a patient deciding about an injection today, the realistic expectation is modest, short-term improvement, and the steroid itself may be adding less than was previously assumed. Bottom line, the LESS trial showed that for lumbar spinal stenosis, the steroid component of an epidural injection adds little or nothing to lidocaine alone at 6 weeks. Both groups improved, but the steroid wasn't doing the lifting people assumed it was. If you're considering an ESI for stenosis, ask your physician what realistic 6-week improvement looks like and what the rest of your plan is. A reminder before we wrap: this is educational content, not medical advice. Talk to your own doctor about your specific situation. If you found this useful, hit subscribe. Next week, we're breaking down the SINZA RCT, the spinal cord stimulation trial that changed how high-frequency neuromodulation is regulated.